So I think, in general, most of our patients will receive one or two operations, but you can go up the ladder if necessary. But with the ablative technologies now, we have often, if we just have a small lesion that comes back, we can just burn it. We don't necessarily always have to go back. We can burn it in radiology, so we don't have to go back all the time. Somebody wants to know what a TKI is.
TKI is a tyrosine kinase inhibitor. The targeted therapies all are called targeted because they target or they affect specific signaling pathways within a cell. And the tyrosine kinase inhibitors inhibit a particular enzyme called tyrosine kinases.
So, Lucas, there's a question for you. What is your experience with somatostatin analogs in patients with sort of a single liver metastasis? Do you have any? You treated lymph node patients without known primary and without liver mets?
Well, I usually all my patients who have metastatic neuroendocrine tumor are put on sandostatin since several years, even before the PROMET data, because I believed in the cytostatic effect of sandostatin. So patients with metastatic disease were put on sando. It's always a matter of toxicity and benefit. Since sando is very well tolerated by patients, it's not like chemotherapy. In my hospital, we were very eager to give sandostatin to these patients. And I have another question related to the sando here. And the question is, when was sando put on the market? Well, it's been there for many years. Oh. There's another question in regards to the acceptable level of 5-HIAA. Well, this level depends on the labs. It depends on where it's done. In my hospital, it's over 50. It's abnormal, but it could be different in Royal Victoria Hospital. So it's every hospital that has its own norms in regards to the acceptable level of 5-HIAA.
Actually, I was using sandostatin when I was in the lab in 1989. So it was under Sandoz then, not Novartis. And, now, I think somebody else is asking a question about reversible versus irreversible embolization. Well, I believe what you mean is if we block the larger artery completely or we don't. What happens is if we rarely use a permanent embolic approach in hepatic artery treatments, because if you do that, you block that artery and you never have access to that tumor again. So what we usually do is use a material that will degrade, or we use very fine beads that go high up into the tumor, into the smaller vasculature. And what that allows us to do is that in 48 hours that artery is open again, although it's given an ischemic insult to that tumor for the 48 hours, but then the artery opens up again, and in 6 months, a year, if you need to go back into that artery, it's still there, and it's still you're still able to treat that tumor. If you block that artery, the tumor will just find other sources of blood supply, sources that you may not be able to get to with a catheter. So you may block yourself from treatment again. That was one. What's a TK? I think that's about it. I mean, I've put them all together. That's about it for the treatments. Is there any other questions that anybody has? Oh, wait. One, what are islet cells? In 2 words or less, okay? Right.
Islet cells are the endocrine cells of the pancreas. So they group together small clusters of cells that are called islet cells. They are called Langerhans cells, and islets, and that's what they are, the endocrine. The cells that secrete insulin, glucagon, somatostatin from the pancreas as the main hormones.
And
I would like to ask a question. Just how I was very interested by results. How do you think these this approach compares with chemoembolization? Because in my institution, even though we're North American, we do chemoembolization. So I'd like to know, how do you think these results compare?
Actually, this is a very interesting question, and it's interesting that we're still looking into it. But we do have, majority of our patients do get chemoembolizations, especially before the TheraSphere has been available. The preliminary results does not show much of a difference. I think it's selectivity. The chemoembolization tend to have more effect on the hepatocytes than so there's more gentler to get the TheraSpheres to the liver than the chemotherapy. But the chemoembolization is more available. I think it's all selectivity and what comes first. A head-to-head comparison is not available. There's no data to talk about this at all. Unfortunately, as many other treatment schemes that we have, there's no head-to-head comparisons. They're all to placebo or to nothing. The good thing is they're not contradictory to each other, so if you had one, you could still have the other. And we've had patients who had both treatments with no problems.
Is there a question from the floor? Or? Oh, sir.
From the basic biological considerations, we know that in radiation oncology, cytotoxic chemotherapy is used as a radiosensitizer in certain protocols. Therefore, there would in principle be an opportunity for a triple threat while you have the catheter in the hepatic artery to administer chemotherapy, the embolic effect of the beads, and the radiation. Is there any evidence that the radiation and the chemo effect would be potentiating each other?
I think we've combined that approach in hepatocellular carcinoma and hope to maybe do the same thing with neuroendocrine tumors. In primary liver cancer, one of the TKIs that's gone through study, went through a phase 3 and has been shown to be beneficial in hepatoma is sorafenib, which is another TKI. And it's also an anti-angiogenic. And theoretically, there should be a window of vascular normalization within the tumor, which means that paradoxically, you're actually increasing blood supply or bettering the delivery of oxygen to the center of the tumor, which is often not the case. Like Mazen was saying, the core of the tumor is often necrotic. And that, the way radiation works is by creating O2 radicals. So if you can increase your oxygenation of the core of the tumor, theoretically you should improve your kill with the radiation. In this case, radioembolization. So we've just completed actually a phase 1/2 combining sorafenib as a neoadjuvant therapy to TheraSpheres. And it does look very promising. So we're actually going to be heading out to a phase 3 study. I don't see why this wouldn't also apply in this type of tumor. These tumors are also quite vascular. In fact, that's one of the things that we notice on CT scan is you see, nice bullets in the arterial phase. Lucas, somebody's asking, is octreotide scanning something that could be used to look at peritoneal mets, or is there other ways of looking at them?
Yes, octreotide scan is a very sensitive tool for metastatic neuroendocrine tumors, but unfortunately for peritoneal carcinomatosis, these scans are sensitive for tumors over 1 centimeter. Unfortunately, most of the time, these nodules are 3, 4, 5 millimeters and are missed. So this is why, unfortunately, for peritoneal carcinomatosis, whatever the origin, be it colorectal cancer, pseudomyxoma of the appendix, or neuroendocrine tumor, the best exam that we have as of today is a CT scan. But it's unfortunately, it always underestimates the tumor. The best exam is laparotomy, which is very aggressive. So, of course, we don't do that all the time.
You have a question there.
Oh, yeah, please.
Carcinoid crisis that would occur when you physically manipulate the tumor. How frequently would you observe during surgery or even during embolization approach? Or just sandostatin or whatever drugs that you're using to suppress is sufficient?
It's not always sufficient, but...
Well, I can tell you, because we do many chemoembolizations, and When patients are well prepared, very rarely does this occur. We had this once in my institution in maybe over 300 chemoembolizations we've done, and this was a patient that was not well prepared. He did not receive enough sandostatin analogs before. So during surgery, and we operate on these patients, when they are well prepared, when they receive these metastatic analogs, well, we saw no cases of this. I don't know if for you with liver surgery, but it's very rare that we see cardiac crisis nowadays.
No, we've not seen. I mean, but everybody's on LAR, and they all get started on a drip prior to the embolization or prior to surgery. So I mean, they're very well blocked. I mean, it would be. But there have been cases where we don't know it's an neuroendocrine tumor. You know, some of the spinal tumors we're removing. One case in particular. I was removing a retroperitoneal tumor, and it turned out to be a carcinoid. And yes, there was a lot of crisis, but we got through it, and we prefer not to do that. The question about primary tumor. Primary tumors is basically where the tumor starts. It doesn't look any different. It doesn't. And we know where the primary sites are in general. You know, they're either pancreas or the intestine. So just to. Look, you want to explain the Whipple's procedure? What do you want me to do?
Maybe you should do it. You're better than I.
So, or a pro can do it. Why don't you do a pro?
So a Whipple's procedure is resection of the head of the pancreas, and because of the intimate relations of the head of the pancreas to the duodenum, which is the first loop of the small intestine, the common bile duct, which actually runs from the liver through the pancreas to bring bile into the intestine, you cannot really take out the head of the pancreas without taking out these adjacent structures. So formally, a Whipple's procedure is a pancreaticoduodenectomy, removal of the head of the pancreas, the first portion of the duodenum, and the common bile duct. And the second part of a Whipple's procedure, once you've taken the tumor and the head of the pancreas out, is reconnecting things so that bile flows back into the bowel, food flows back into the bowel, and pancreatic secretions flow back into the bowel. So there's a resection phase to a Whipple's and a reconstruction phase.
Great, thanks. Is there anything from the floor?